It's my pleasure to introduce the speakers for the afternoon. And our first speaker will be Dr. David Barzilai. He is a leading longevity medicine physician and consultant dedicated to optimizing health span through evidence-based precision medicine and longevity best practices for individual and institutional clients. As the founder and CEO of HealthSpan Coaching, LLC, and an inaugural faculty member and trustee at the Geneva College of Longevity Science, his pioneering work, rooted in his PhD in health services research, applies the latest scientific advancements to enhance vitality and extend healthy lifespans.
How's everybody doing? This is day 2. You're at the 3/4 mark. And it's been an exceptional journey, hasn't it been? What I love about the conferences is connecting with people, connecting ideas, collaborations, relationships, and a common vision. So today I hope to share with you a vision I have of what the essence of longevity medicine. We have a diverse audience here today. So I kept it short and sweet. And these are just my own elements. There's also a Healthy Longevity Medicine Society, and they just updated their definition about health span through the lifespan based in aging biology. But there are many perspectives, but what unifies us is we want to use the best available tools to increase the health span, longevity, and quality of life, meaning and purpose for our patients. So this is all through my eyes as a longevity consultant and physician, where I try to find what are the best practices, everything from lifestyle medicine, things you and I can do every day, like eating whole foods. You saw the whole foods, the salmon and the vegetables out there, exercising, took a little stretch break, to the cutting edge, meeting the best practices right now today in precision medicine, and even looking ahead in aging biology. So these are exciting times. And it's also exciting because these advanced. My last talk, they didn't advance. It was a lot of fun to experiment. So what is longevity medicine? There's no single uniform definition of what longevity medicine is. Some have been proposed, including I mentioned before, by one major society that's doing fabulous work by Andrea Meyer and Evelyn Bischoff and others. You can think about it improving the quality of life throughout one's life using the best around from the aging biology principles, like what are the fundamental root causes that makes us age, that produces these chronic diseases, as well as things we all can be doing every day, which we just touched upon, right? Eating, stretching, moving, relationships, purpose. So I think it should be interdisciplinary by nature, and I'm just going to be covering a few elements rather than having a single unified definition, which should be something we as a community generate, but these resonate with me. So this was actually the earlier definition before the recent update, longevity medicine upskilling the physician workforce of tomorrow. It's a good reminder that we should be thinking ahead, that how are we going to train the people to do the work we want to for this to reach people. So one definition out of this was Evelyn Bischoff or Eva's work with Alex from In Silico Medicine. Longevity medicine is advanced, personalized preventative medicine powered by deep biomarkers of aging. What's a deep biomarker? Well, some of the definitions in the literature relates towards like deep learning and AI and analysis. So you can sort of track people based on all these parameters, what their health status is, and are they on track. It's rapidly evolving area, biogerontology, geroscience, precision preventative, and functional medicine. And I also mentioned the more updated definition earlier, but I'm going to kind of modify this, highlighting a few themes that resonate with me. So the aims of longevity medicine, as we covered, is to delay, slow, or reverse biologic aging, to be versatile, walking around tables, sorry, I couldn't resist, integrating the advancements of genomics, AI-driven diagnostics, regenerative therapies. These are all potentials, and some of these need to be validated in humans for us to have more confidence for specific applications. But something I want to emphasize is it's not living longer is great. I'm not a living longer is great denialist. People who have a wonderful quality of life with family, they tend to say, how about another year, even if they said I'd be happy at this year, right? But also the quality for life, right? We don't want to be bedridden and unable to contribute to the world and to have the physical and cognitive capacity we'd had when we were younger. So this is actually one way of describing it. I always have the DOIs at the bottom if you want to look up the citation. But on the left, we basically see a shift right, what we might expect if it's parallel, if you're just extending longevity, which is great and an important goal. On the right, we're seeing something else, another important theme, the ratio between health span and sick span. You see, what typically happens when we have a modern sort of sick span paradigm for treatments is we may extend the lifespan by a little bit, but by not too much. And what ends up happening is we're kind of living with chronic diseases. We're managing. We wait till the diabetes occurs. Dementia is diagnosed. Sometimes we could do some things intermediary, like mild cognitive impairment for dementia and prediabetes for diabetes, but we're still relatively distal in that pathway, or distant in that way of looking at health. So what we really want to do is not live longer so we spend more years sick. We want to extend our healthy years. And yeah, why not push the whole thing forward? That's what this means. And there's actually a statistic. This is eliminating one disease at a time. This is in principle extending health span by addressing this biology of aging, right? There's a statistic. Does anybody in the audience know if we cured cancer, by how much longer we would live on average? Yeah, about 3 years. See, it's a diverse audience with an eclectic talent and knowledge here. But that's J. Olshansky's work. And he's recently had another excellent publication. He's prolific through his lifespan, his multi-decade career, something which is part of health span. So why is it curing one disease, cancer, would extend by 3, and then if you maybe by another year or 2, if you do heart disease too? It's because our biology of aging is aging. We're getting older. Everything is sort of breaking down, whether you call it signaling, molecular damage, whatever models you have for aging, things aren't working like they are. Entropy is increasing. So if one thing doesn't get you, if the cancer didn't get you, guess what's going to get you? The dementia, the heart, something else, and everything declines. So we want to get ahead of that. Even a small percentage of something that addresses this biology would take us much further. And this is my mission. This is when I'm not consulting for clients, individuals, and organizations on evidence-based best practices in precision medicine and tailoring that. I'm trying to catalyze this field forward. This is what brings us all here, right? We're all part of that. So just a little contrast quickly. Precision medicine versus preventative medicine and lifestyle medicine. I want to just clarify this a little bit for us here. So precision medicine, what is it? It's basically a high-tech version of personalized medicine. We all have different genes, right? What works for you might not work for me. It might be the wrong dose. Maybe it's the wrong treatment. There are things in common, but sometimes there are relevant things that are different. Every cancer is different. Every cell in every cancer is different. So precision medicine looks at that. Preventative medicine also looks at kind of how to prevent things. But in contrast, longevity medicine, it's also about thinking about aging biology mechanisms and things that address that. So lifestyle medicine promotes healthy habits, and longevity medicine enhances this with technologies like AI and regenerative therapies, and the goal is to extend our health span and our lifespan. This is just another quick way of seeing it. This is a short presentation, but here's the gist. On the left, that's like precision medicine. Let's say we have all our data on the cloud, everything from wearables to blood pressure, functional markers, or VO2 max, or heart rate variability, to omics and other more cutting-edge ways to study more on the molecular level what's happening. And based on predictive modeling, such as with AI approaches, like generative and other models, we can help hopefully come to more recommendations. And we're just at the cusp of starting this. And what's lifestyle medicine? On the right side, I'm also a diplomat of the American Board of Lifestyle Medicine. And that's basically you're certified as a diplomat in an exam training where it's exercise, diet, nutrition, et cetera. And how do I think these things work? I think these things work by addressing the biology of aging. I think that's why they work. So take a moment to read this caption. Wouldn't it be nice if we had, a pill, right, to take care of everything? I believe that while lifestyle medicine can only take us so far, for anyone in longevity medicine, the elephants in the room, if you're not addressing it, everyone should. Lifestyle medicine, health habits, and best practices in medicine, including early screening and detection, is a cornerstone. It is where 99% of the evidence is, and 90, 95, 99% of therapy when done best. But I would like to see the needle moved, so remember that earlier graph I was showing you? So we can move that health span out forward, because we can only take things so far with that alone. So in lieu of that, I'm going to skip this just for time, because I enjoy getting carried away with examples. So those were the old versus the new hallmarks of aging. They're not exact things. There's the hoverfly and the wasp by Pedro. Vadim Gladyshev wrote something shorter, another critique of the hallmarks. They're useful. What's a hallmark of aging? It's a buzzword. What does it mean? It means that they're biological processes that A, correlate with aging. B, if they go wrong, they get worse, then the phenotype or appearance of aging gets worse. And by appearance, I don't mean just skin, I mean everything function. And C, it means the opposite, which is the hardest to show, but all of these to some extent show that if you can actually improve it and make it better, that organism does better. Like, for example, we see there's this biology of aging. We can take a rodent, can live multiple-fold longer from a 2 or 3 year old up to lab rodent to a naked mole rat that lives multiple-fold longer. What's the difference between the two? They're both rodents. It's not that many genes. Well, what we found from comparative biogerontology, that is looking between species, we found that if we take a particular SIRT6, a particular sirtuin, and we have a really efficient one from a long-lived organism, and we put it in a shorter-lived organism, that shorter-lived organism lives longer. That's an example. So these hallmarks are important as a vocabulary, but as a target. They let us justify our grants, explain ourselves to colleagues, but they're things that explain and we can focus on to have innovation. This is just another way of looking at it. There's change at the systemic, cellular, molecular. It's at every level. It's the same thing if you look at, you can cut through the skin or heart of any one of us every 10 years. We can tell the difference. You can say, this person's about this old. It's that process we're addressing. So this is another paradigm. This is Brian Kennedy and co-authors. Pillars, hallmarks, same kind of thing. And this is the point I made earlier. I hope this is a pointer and I don't turn off my slide. Good. Okay, so exercise. You can see it molecularly targets these. Okay. So this is something interesting about those hallmarks. SASP, senescence-associated secretory phenotype. These cells, sometimes people call them zombie cells. They're not really zombie cells. They're actually super active rather than undead. They're multiply with time. They are neither dead nor are they functional, and they cause local tissue damage, and they produce kind of this contagion. That's why they call them zombie cells. Other cells become senescent near them. In some animal studies targeting even like that small percentage of our cells are senescent, we've seen some improvement. It's more complex for humans. We're studying it. But look here. This SASP, this hallmark of aging with senescence, it does all this. Your eyes, your bones, your liver, your heart. All that stuff from one thing. I'll show you another example. This is there's a mitochondrial dynamics. There's fission, there's fusion, mitophagy. You might have heard of the autophagy, or gobbling up of mitochondria. These power cells, which are also very important for signaling, and they produce a lot of reactive oxygen species. They're doing all sorts of stuff. But the bottom line is they go wrong with age, the way they, as a network, behave together and recycle. And these are all the things that happen when they go wrong, right? Dementia, problems with your eyes, problems with your hearing, etc. And you know what else is interesting? It's not just one hallmark causes all of these problems. It's also, if you target one hallmark successfully, in a model organisms, from yeast right up to fellow mammals when we've studied it, with a few pseudo-exceptions as far as we've gone, which is why I'm excited we're at the cusp of the next step in humans, is we're seeing if you target one hallmark, the others, or many of the others, get significantly better. They're interrelated. We have a systems biology at multiple levels in three-dimensional space-time where we have these nodes we can affect that can affect other parts of the system in exciting ways. So evidence-based longevity medicine, I'm going to focus on evidence-based medicine the next slide. We can skip this, again, for expediency. This, by the way, is outdated, the pyramid of evidence and evidence-based medicine. It's really, it depends. Something can be at the pinnacle that's more like the base or vice versa. It depends on the quality. The point I have to make here is in aging, biology, and longevity medicine and science, you know, I'm a diplomat of I'm the Geneva College of Longevity Sciences, first executive masters of science in the world in longevity, which I'm excited to be a trustee there. We're talking about this longevity science, and a core issue when I was talking to the students, we just had our opening up, and I had the honor of doing the keynote address, and it's like, here's the problems that you need to address here. We can't do a randomized controlled trials in human beings at birth. You're doing this, you're doing that, and follow them for a lifetime and see what works. That's a considerable challenge, but it's also an opportunity. Because we're cultivating these biomarkers or ways to track what change is occurring to try to get it sooner if something's working or not, so that we can see if something works, so we can prove something works, so we can get it approved and get it to patients. That's what it's all about, right? So the other reason I have this pyramid up here is that we as longevity physicians, I think it's important we acknowledge that the aging biology aspect of it is the weakest in terms of where we have evidence right now. But I do believe this. I do believe that educated, informed individuals, and this is where truly foundational knowledge is important, that relationship you have with someone, is people can make educated decisions whether or not to take a multivitamin or a particular intervention, off-label, any number of things. They need to understand the evidence so that they can make a choice for themselves. And that's what it's about, doing so in a responsible way that balances and prioritizes first transparency and clarity, so it's an informed decision, and also with patient autonomy. And our decision, you know, we're in a lifespan where death is inevitable, right? And decline is inevitable. So we should have a choice for things when we're at a preclinical stage, when to or to not in a responsible way. So evidence-based medicine, I like this definition. It's from David Sackett, the father of evidence-based medicine. Back in the day, I designed a curriculum, also published and taught evidence-based medicine, which is basically how do we take all this information that physicians use and do it in a systematic, logical way. Doctors have some training in that, but I think it's something that can be more optimized and scaled in implementation across the board. So it's evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Did you see what I just said? I just said something that actually, let's not have it lost. Evidence-based medicine isn't following clinical guidelines that are for the average patient in the average trial. Evidence-based medicine is about using your clinical judgment and what you know about the patient, your experience, that whole hierarchy of evidence, rather than all of these non-existent randomized controlled trials, lifetime in humans. It's integrating that in a sensible way. So that's what I think is that kind of medicine 3.0 paradigm, where we can have this discussion around evidence rather than this is true for the average person, therefore it's true for you, and we're going to wait until this point before we have a discussion. We discuss it now as the evidence emerges. I wish this was a true before and after picture. How about you? Until we have these kind of solutions, it's going to be a conversation. We're nowhere near there. but we're on a very exciting track with the fast exponential change we're seeing in the laboratories. So risk mitigation, I'm going to just in my final minutes talk about just a couple things we can do. Therapeutics is a whole other talk. So let's just talk a whole other series, one long lecture per topic. So risk mitigation, that just means we can mitigate our risks through our habits right now. I know I don't have a lot of time, so I'm just giving you the highlights. Health surveillance. There are things we can do right now that we used to be so afraid of false positives. That's accidentally saying someone has something when they don't, that we have, in my estimation, started to underscreen for potentially serious conditions because of excess cost or fear of it leading to iatrogenesis or medical harm. I think it's important to figure out the number needed to treat. That's how many false positives or number of people who don't really have it are told you might have it, and them being scared, oh, you don't have it, or them going in. So it is a part of the dialogue, an important decision. But I'm saying whole body MRIs, I am personally a believer of this, as an example, at some frequency. Let me tell you why. And this is just a whole bunch of other things that can be done. We can skip that. And I love this from Qi longevity, this kind of linking biologic phenotyping and therapeutics. But these are statistics. This came out of early data from Health Nucleus, another center. 1.7% of patients who had no symptoms whatsoever were found on MRI to have a tumor, and the majority of those were malignant. What do we know about cancer? For all of the attention about the breakthroughs made, for the lion's share of solid tissue malignancy, it's all about catching it early. And if you don't, the things we have available are limited, and in many cases, the time limit today in 2024 and for the foreseeable future. So screening people early, that 1.7%, a number of them may have been able to have it cut out while you still could. So we should invest in the technology, but use the best of what we have right now. That's my premise. That or repairing an aneurysm, things like that. This is a whole nother series to talk about AI. AI is doing everything, okay? It's one of my passions, areas that that biomarkers of aging, translating policy regulation, access, equitability, global health span. This is one of my areas of deep passion. No pun intended, deep learning, but deep passion. AI can do much more than even all of the body of people put together, because it can keep so many more variables in its head at the same time and mathematically find connections. It can do so for drug discovery. It's even done so for drug design, saying, these things worked. What do they have in common that might work? And then you can screen it. Literally every step of the cycle, and you can follow this on your own. I usually have the DOI, but there I have the title there. It's at every step. And at the point of care with physicians in real time. Because even the best doctors who read all the time, they are optimally leveraged, all of their talent, all of their years and years of education, by not just staying on top of literature and having the skills to read the literature critical, which I think is an area we can be targeting more consistently and reliably too, but also using the best tools. AI second opinion, you can say, oh, AI is dumb, it's hallucinating. Or you can say, hey, wait a minute, this is interesting, it does inform care. So I think that best practices should be that, interdisciplinary, patient education, patient empowerment. They and the clinician are collaborators in better health. And all sorts of exciting things. We're here at the bottom there. I had just updated this from the first annual to the second annual roundtable of longevity clinics. That's about happening. I'm just telling you now, we live in exciting times. I told you about the school that just opened this year. There's longevity education, free, continuing medical education. Another one of Eva's products, Eva the Incredible. Healthy Longevity Medicine Society, Andrea the Incredible. Academy, all these things happening. This is just happening all at once. Why? Because finally we're at a point where we understand these mechanisms well enough, and we're seeing therapeutics. We didn't even talk about rapamycin and other classic cases from the interventions testing program that are extending longevity, actually doing it in other fellow mammals. And that's a big old QR code if you want to stay in touch. On X, I would say the majority, probably significant majority of aging labs follow me on X, or formerly Twitter is @agingdoc1. I think people who are in this space already know that, so I put up the one instead for LinkedIn if you want to connect with me and you're in this space. I'm trying to build bridges with my time to expedite the field. I'll be speaking at the Hevolution Foundation in February. Singapore will be hosting the NUS Longevity Founders Forum. There's a lot of exciting things happening, and it's just a privilege and honor to be here and share with you just a small taste of it today. Thank you.
I have a question about measurement. Interesting example with the cancer. If you measure someone, there's cells that turn into cancer cells all the time. And we have intrinsic mechanisms, P53, whatever, that remove cancers. We don't know the trajectory that this cancer will take. If we start measuring everybody, are we not taking a risk to generate a population of hypochondriacs?
I think it's an excellent question. My original training, as a PhD, I've been following neuroscience literature for decades after, BS in cell and developmental biology in 1993. But something that, as a health services researcher who looks at not just outcomes from trials and observational studies and other clinical research, the other aspect of my PhD, housed within a department of epidemiology and biostatistics, is looking at the delivery of care and the implications. Clinical decision analysis is one field within that when you look at cost and quality. Economic cost as well as personal cost. So back when I was in training, there was a real concern. People were talking about, should we screen smokers with chest x-rays? And there was controversy in there. For those of you who aren't clinicians, and chest x-rays have improved since then, but chest x-rays are extremely crude. So if you're looking at an image of a chest x-ray, what you're really seeing is like a little white blob, which may be nothing. So the problem is, which you're illustrating with your question, it's not just the anxiety of having potential false positives, but it's also, now what do? Do you go in there? Okay, you're going to take a little biopsy there. Well, a little biopsy, you can get a pneumothorax, you can puncture your lung. Maybe you never had a lung cancer, but now you have a punctured lung. This is where number needed to treat, a paradigm where we weigh what are the potential benefits and probabilities. Well, technically number needed to treat is the number of unacceptable outcomes or bad outcomes for the number of good outcomes. Usually the bad outcome isn't so bad, but the good outcome is very important, like saving your life. So I think about this, for example, in dermatology. If you see a suspicious mole, how many times are you willing for a mole to look like that, to biopsy, to save one life? Now, a biopsy is not trivial. There's a risk of infection. You have a pinch and a burn. There's a cost to you, the healthcare system, probably both. You'll have a scar there. It takes time to heal. And other issues, right? That's not trivial. Saving your life is bigger. When looking at things as a dermatologist, if you literally said, well, I don't want to cause any harm, I only want to biopsy the ones I'm sure is going to be a melanoma. Do you know what's going to happen? You're going to miss a lot of melanomas. If you ones that are pretty sure is melanoma, you're going to miss melanomas, you're not going to miss as many. Now, you don't want to be, oh, it's dark, I should biopsy it. I'll give you a schenectomy. That's bad too, that crossed the line. But you need to decide where that ratio of risk to benefit is. And I would add, besides number needed to treat, you need to think probabilistically as another dimension for that. Probabilistically for the risk, the benefits through this multivariate of all the risks and all the benefits. So in answer to your question, I think it's a legitimate concern, and it should be operationalized from a way that's both quantitative as well as tailored. I advocate for my clients a real tailored precision approach. you can have two patients with identical biomarkers, but one person has a family history or is afraid of something that happened to his father. They're the ones afraid of procedures. These things are factors too. You need to know your patient, you need to have a conversation, and need to discuss these numbers and data together so you can make a joint decision making. I hope that helps.
Thank you, David.
Thank you for having me. It was a privilege and honor.